It is indeed a wonderful event. It's been growing in each of the last few years, and the organizers have done a fantastic job, and I really look forward to seeing continued growth of this conference and extension of its mission going forward. Again, I had clinical responsibilities at the hospital today, so I apologize I couldn't be here sooner. But I was asked to come and speak with you about some basic issues pertaining to COPD. And I know that this is a familiar topic to many. I'll give you my take on it. Some of this, I hope, some of you have heard before. It should sound at least familiar if communications are going well across the board in our healthcare system. Next slide. So first, let me just begin by reading for you the accepted current definition of what is COPD, because actually it's a quite heterogeneous condition, and we'll talk some more about that. So what is it? We define it as healthcare providers as a common preventable and treatable disease characterized by persistent airflow limitation, airflow obstruction, and we're going to come back to that in just a moment, that is usually progressive and associated with an enhanced chronic inflammatory response in the airways and the lung to noxious particles or gases. Exacerbations and comorbidities contribute to the overall severity in individual patients. Now we're going to dissect that big definition out a bit. Next slide, please. So COPD includes more than one entity, and sometimes this is confusing because people use different terms at different times in different places, and it's hard to keep track of what really is all included in COPD. So COPD includes emphysema, which is actual destruction of the air sacs of the lung. We'll come back to that. Chronic bronchitis, which is a chronic inflammatory process of our airways or bronchial tubes. Next. And there's overlap, actually, between asthma and COPD in some cases. So all of these entities are included in the condition known as COPD. Next, please. Let's just take a step back and do a brief anatomy lesson, just so that we know exactly what we're talking about in terms of the airflow limitation and obstruction. So when we breathe air through our nose and our mouth, it goes down our trachea, which is our windpipe. And in the center of our chest, behind our breastbone then, that main air passage divides into two. One that goes to the right lung and one that goes to the left. I don't know. So inside the lungs, this air passage on each side branches into smaller and smaller and smaller. Thank you very much. Dividing airways. Okay, so here's our trachea, and it comes down and divides within each lung into smaller and smaller and smaller set of branching tubes that carry the air from the outside to all the different parts of our lungs on both sides. If you envision this, the way it looks three-dimensionally, it's rather like the trunk of a tree that divides into primary branches and then smaller and smaller branches going out every which way. These tubes are called the bronchial tubes. When they're inflamed or infected, that's called bronchitis. But that's not where the gas is exchanged in our lungs. That happens deeper in. And at the end of each one of these tiny little bronchial tubes throughout the lungs, each one opens up into a little cluster of air sacs, which are like clusters of tiny little balloons, which are very elastic under healthy conditions, and which, when you breathe in, inflate up, just like balloons do, and when you breathe out, they deflate spontaneously, just like balloons do if you take the end of your fingers off the end of the balloon. And if we look at this area, this is where actually the gas exchange takes place. And what's not shown on this picture, but the heart sits between the two lungs and is actually connected to the lungs. Next slide, please. There is actually, in addition, this is sort of just a cast model of what the lung looks like. Here's our trachea, our main bronchial tree here, and then all of these branches three-dimensionally and shown in white. But you can also see that there's a network of blood vessels that runs right in parallel with each and every one of those bronchial tubes. So everywhere the air goes, the blood goes too. And around the outside of each and every one of the walls of those little air sacs, these blood vessels envelop them, and you have an exchange of oxygen from your air sacs into your bloodstream, and you get rid of the waste product. So this cast model here just illustrates how extensive this network of branching air passages and blood vessels is. And I'm using that to raise the issue of where is the airflow obstruction in COPD. In fact, it depends on whether one has that chronic bronchitis component or emphysema or both. So if we look at this slide, you could see the structural changes in the bronchial tubes that lead to airflow obstruction. We have up here on the top a figure that shows what a healthy air passage looks like if you cut through it, and one that has chronic remodeling and inflammation in it. And it's pretty easy to see that the healthy one is more open for air to pass through than the other one, where there's this chronic inflammatory process. Some people have lots of excess mucus that contributes to chronic bronchitis, but not everybody does. Some people have that only if there's an infection. If we look at what it looks like under a microscope, if we take one of the tiniest little air passages, here again is a healthy one. It's wide open. It has a nice thin wall there. There's not a lot of stuff around it, and these are the air sacs nearby. And this, on the other hand, is one when there's COPD. There's tremendous inflammation, and the air passages are narrowed. Next slide. If we look at what emphysema looks like, this up here on the left is what it looks like if you cut through, almost like the surface of a sponge, healthy-looking air sacs in the lung. And here is an example of emphysema, where these nice tiny little air sacs are all destroyed, and you see these big dilated air spaces, and these don't empty well. They trap air inside that is stale air, and they don't contribute well to gas exchange across their surface into the bloodstream. Down here on the right is a picture of what a CAT scan looks like in someone with some emphysema. And again, this is a cross-section through the body, and we see over here that's our windpipe coming down. These slightly grayer areas of lung are the healthier, preserved lung, and these dark black areas are areas of destroyed lung with emphysema. Now, COPD commonly has a mix of both of these things. Next. So how do we diagnose COPD? In order to diagnose it, we need a history of symptoms that might suggest it, things such as shortness of breath, wheezing, cough, and for some, not everyone, sputum production or mucus production. And we need an exposure to relevant risk factors, which the majority of time, at least in this country, is exposure over time to tobacco smoke. And that could be primary smoking. It could be passive smoke exposure as a child or elsewhere, for example, in the workplace. It could be cigar smoke, marijuana smoke. Any kind of smoke can do this. Some occupations are at increased risk for this. And in other parts, this could happen in our country as well, but in other parts of the world, a key contributor is exposure to things like indoor wood-burning stoves and biomass cooking fuel exposures. And then other factors, things like early childhood frequent infections, other mechanisms such as an accelerated aging process, and other factors like genetics contribute to the risk for COPD. As you all know, not everybody who's been a cigarette smoker or tobacco user or who's had some smoke exposure, not everybody actually gets COPD. So there are some genetic risk factors, and key amongst them is alpha-1 antitrypsin deficiency, which is an enzyme which, when deficient, predisposes people to getting COPD, and in particular emphysema principally, but not solely. So to actually diagnose it, we need something called spirometry. That's what's shown in this slide. It's a type of a lung function test. This is a gentleman here shown in the seat, breathing in through a tube, and there's this machine over here now. It's a digitized process. And lung function tests, maybe many of you have had them at some point. What they do is they measure how much air you could get in and out of your lungs, how fast you could get it in and out, and the efficiency of that gas transfer across the air exchanging surface in the air sacs. When a person takes a big breath and blows out very hard, we're measuring not only how much air you move in and out, but how fast you can get it in and out of your lungs. And when we see that it's reduced the pace at which you can exhale it, then we know there's airflow obstruction, and we have to figure out what's going on as why. Next slide, please. Okay, so this shows you, again, those cartoon figures up here, or photographs. These are a microscope slide over here. This is the airflow obstruction at the level of the airways. This is a tissue destruction with emphysema. Whichever combination of these is present in a person's lungs, the result of that is that there's obstruction to the flow of air. Means that there's more resistance to moving air through your lungs, and that leads to several consequences. One is that your oxygen levels may be lower and carbon dioxide levels may be higher. So this puts a bigger requirement on your breathing. At the same time, that increased resistance to the flow of air and the obstruction means that you tend to trap air behind in your lungs, and your lungs get overinflated. That could happen when you're sitting still at rest, but it could also get worse. It usually gets worse when one exerts oneself and you're breathing faster. When your lungs trap stale air and become overinflated, that puts your breathing muscles and your chest wall into a distorted position, and your breathing muscles can't work as effectively for you, and that decreases your breathing capacity. So here you could see this is not a favorable thing, because on the one hand, we have increased work to move the airflow through those narrow tubes. We have an increased breathing requirement if our oxygen levels go low, and yet we have overinflation of the lungs with decreased pump ability, if you will, to move the air in and out. So this is the common set of circumstances when we have COPD. And collectively, this poses a tremendous burden on people in the way of symptoms: shortness of breath, coughing, wheezing. Leg fatigue is another common symptom that people experience. There's a tremendous psychological burden in terms of anxiety, fear, becoming sort of more isolated, concern to do activities, and there's tremendous impairment of exercise tolerance. And this does not necessarily mean, going for a run that's 10 miles long. We're talking about getting through the day, doing daily activities that may just even include dressing, bathing, and caring for oneself and one's home. So the exercise tolerance is actually, importantly, not just about the structural changes in the lungs. People commonly have limb muscle dysfunction as well, and some concurrent heart impairments that can contribute to the exercise intolerance. And that's an important thing for us to know when we see people with this condition. And all of this together reduces people's quality of life often. Next. So in addition to the changes we've already talked about with COPD, the structural changes in the lungs, medical comorbidities are common. And that really means, said a different way, concurrent medical conditions. And there's a spectrum of them here that I've shown on this slide, but just to illustrate, sometimes the limb muscles, particularly those of the legs, are dysfunctional. And this is one of the important reasons why we think about pulmonary rehabilitation, because if we can improve the function of the leg muscles, it puts less demand on your breathing when we do physical activity. But other things like osteoporosis, anemia, sleep disorders, lung cancer risk, anxiety, depression, frequent infections, and acid reflux, and very importantly, a variety of different types of heart disease are commonly seen in association with COPD. And not just one condition at any given point in time, but in fact, multiple comorbidities are common in people with COPD. In fact, there have been studies that have shown that amongst people, large cohorts of people with COPD, many, more than 50%, more than half, have 4 or more medical comorbidities. Okay, so to manage an individual's COPD also means being aware of, identifying, addressing, and managing those conditions as well. And it's important because comorbidities actually worsen quality of life, increase disability, worsen the risk of exacerbations, increase healthcare utilization needs and costs, and indeed increase mortality over and above the risk conferred by the COPD itself. Next. So we have to identify those. Next slide, please. So if we look then at the overall vicious circle of chronic obstructive pulmonary disease and how a person may be affected, we see that the structural and functional changes in the lung and the secondary effects on the breathing muscles and the chest wall lead to breathing impairments and gas exchange oxygen level, for example, disturbances, increased demand on the breathing with shortness of breath. And sometimes there's limb muscle dysfunction, which contributes further to that activity intolerance, along with shortness of breath by itself. The legs don't function as well as they should. Other comorbidities like heart problems and arthritis and other factors can contribute to that exercise intolerance. All of that, having limited ability to do activities as well as shortness of breath, both factor into a reduction in quality of life related to your health, anxiety, depression, fear, social isolation, low physical activity levels, which leads to deconditioning, which then creates a vicious circle back into all of this. So this is our task as collaborative healthcare provider with individuals affected by COPD to try to interrupt this cycle. Next. On top of that, we have the acute exacerbation. And most of you have probably heard of acute exacerbations or experienced them. These are episodes where there's acute worsening of symptoms beyond the day-to-day variation that is usually typical for a patient with COPD. But these exacerbations result in the need for additional therapy, change in medical treatment, at least temporarily. They are associated with worsened airflow obstruction, worsened inflammation in the lungs, even harder to breathe, and everything that we just talked about before in terms of the work of breathing and the demands and the gas exchange disturbances get worse during exacerbations. They can be very mild so that they can be handled on an outpatient basis. They can be sort of middle of the road, or they can be very severe and end up landing someone in the hospital. And sometimes they lead to outright respiratory or breathing failure and require assisted breathing support. Next. So these exacerbations in and of themselves worsen airflow, worsen symptoms, worsen a person's ability to do their daily activities, their health status, quality of life, and again, they also contribute to healthcare utilization needs, healthcare costs, and mortality risk. So we have to figure out what to do about them as well as the comorbidities and the underlying condition. Most acute exacerbations, probably about 2/3, are triggered by some form of infection, either viral infection or bacterial infection, or it might start with a viral infection and get a secondary bacterial infection or bronchitis. When its phlegm is all thick and yellow, that's when to think about needing an antibiotic. Not always, but that's when there should be communication with a healthcare provider to address whether or not antibiotic might be needed. But note also that changes in environmental conditions can trigger these exacerbations. For some people, it's a change in temperature and humidity, cold, dry air, or hot, humid air, or air pollutant levels being high. And for some people, it's acid reflux that they may not know that they're having, because you could have acid reflux triggering exacerbations of COPD without any heartburn whatsoever. And in some cases, we just can't figure out the actual cause. Next. Back one, please. Just to keep in mind that many things can actually mimic COPD exacerbation. So not all things that lead to an increase in breathing difficulty in a person with COPD is actually a COPD exacerbation. And the things that commonly get mistaken or masquerade as COPD exacerbation are things like heart failure, pneumonia, blood clots to the lungs, and various other conditions. And that's important because if you end up with an exacerbation and the problem is heart failure, which may have very similar symptoms, and you throw all the medicine in the world to treat a COPD exacerbation, it's not going to be the right direction to go in. And at the same time, you're not necessarily getting the treatment for the condition that may be causing the problem. So that's just something that all of us need to be aware of. Next. So if we look at this picture as a whole, we have the underlying disease, we have the comorbidities, and we have these exacerbations. And collectively, all of them together contribute to the functional disability, symptoms, impaired quality of life, healthcare utilization, needs, and mortality that is part of this conundrum that we call COPD. Frailty, I will mention, is common as well. In fact, having respiratory impairment is a risk for frailty. Having frailty is also a risk for having respiratory impairment. So addressing the systemic aspects of this, muscle conditioning, skeletal muscle dysfunction, general mobility, is a really important part of managing this. Go ahead. Next one. So we need individual treatment that is multidisciplinary. So all of that I've just been talking about informs the currently recommended overall assessment of a person with COPD. First is, we need lung function testing to confirm the diagnosis, and to perhaps rule out other conditions, and to assess the severity of the problem. Next. We need imaging. We need usually a chest x-ray at least, and in some cases a CAT scan is very helpful and informative to help distinguish regarding emphysema, its presence, its absence, its location in the lungs, and whether there's airways inflammation and or other problems. Symptom assessment is very important, looking at the severity of symptoms at any point in time, and there's a variety of questionnaires that we can use to do this. Next. We usually measure exercise tolerance over time, periodically. Not every single visit to a healthcare provider is it necessary, but once every year, every 2 years, it's recommended to do a 6-minute walk test, for example, to assess how far you could go when you're walking at your own pace, whether it be with your oxygen, whether it be with a walker or a cane or whatever you usually walk with. We assess exercise tolerance like this. There are fancier types of exercise tests on treadmills and cycles with all kinds of equipment, but those are not always needed and they are more cumbersome. So the 6-minute walk test is most widely used for routine assessment. Next. We need to assess what your exacerbation risk is, and that the best predictor of that is actually a history of previous exacerbations is more likely to tell us whether you may be at risk for future ones. And when someone has a history of exacerbations, we have to look hard to see what the triggers might be to try to interrupt that cycle. We look for comorbidities. We look for your blood count to see whether there's anemia. We look at an echocardiogram to look at the heart function. Bone density testing is recommended at least somewhere along the line to make sure your bones aren't at risk for fracture, etc. And there are these different types of multidimensional sort of disease assessment tools that are out there in the literature that can help predict prognosis. Those are things like composite measures of, for example, body mass index with the severity of your airflow obstruction, how bad the shortness of breath is, and what your walking capacity is, things like that. And those are useful, but they're more useful on a population basis than on an individual basis. So they're not always done, and they're usually not communicated to people with COPD at healthcare visits, you know, at every single visit, because it's more of an overall risk assessment tool. Next. So how do we manage COPD when it's at baseline, not in the midst of an exacerbation? Well, our goals are several. The first is to relieve symptoms and improve activity or exercise tolerance. And again, exercise is being used widely or loosely here, not to mean necessarily going running, but rather doing activities of daily living. Improving health status and quality of life, preventing disease progression, preventing and treating exacerbations, and helping people live longer, hopefully with an improved quality of life. So one other thing I want to say about that, and it went by kind of quickly, but disease progression is variable. While it's true that, in general, COPD is a gradually progressive condition over time, the progression is very variable in its pace. And there are some people who do continue to progress very steadily and very rapidly, but there are many, even who have very significant and or outright severe COPD, where you get that degree of COPD, and if you interrupt the cycle of exacerbations and you do optimize everything else, things could stay very, very, very stable for a long time, and that's the goal. So importantly, no nihilistic view such as, well, you smoked, so what do you expect? That should never be undertaken, right? This should be a focus on wellness. Okay, next. So the choice of actual treatment depends on individual symptoms, depends on your comorbidities. So for example, there may be some treatments more appropriate than others depending on what else is going on in the body. For example, if you have a history of a certain type of heart rhythm disturbance, there may be things to avoid, right? So choice depends on what else is going on. It also depends on how severe the lung function impairment is, your exercise impairment, the exacerbation history, and preferences. Some people just don't like one type of a treatment or another. They have preferences, they've had a bad experience with one or a great experience with another. This factors into the choice as well. Next. So the mainstays of our treatment for COPD, next. First is smoking cessation. I think that goes without saying, and I say that also loosely. It means not just smoking cessation if one is smoking on, as an individual, but avoidance of secondhand smoke as well. So it's important to avoid smoke in restaurants or casinos or other public places where there fortunately have been efforts to minimize general public's exposure to smoke. But it's also important to make sure that family members aren't smoking around you and exposing you. So smoking cessation used broadly. Being up to date with your immunizations, annual influenza vaccine. And also there are two types of pneumonia vaccines, and they have different treatment regimens. One's just once in a lifetime, that's the Prevnar 13, and the other one is at 5-year intervals. But they also can't be too close to each other. So you have to talk to healthcare providers about that. Inhaled medications are our mainstay of medical treatment. There are short-acting and longer-acting agents. One of the mainstays are a treatment group of medicines called bronchodilators. They relieve the muscle constriction in the bronchial tubes to help them open up. And different classes of those medications, and they come by many, many trade names, and a lot of them are cousins of each other. And if you look at the TV ads, they have everybody convinced that the one that they're on is the worst one ever, and they should get this other one. But frankly, a lot of that is just advertising. There's a lot of things that are comparable across the classes of medications. There are two key classes of bronchodilators, and they work differently so they can add benefit to one another if one's symptoms aren't controlled on one class or the other. But don't be too fooled by a lot of the TV ads that make you feel like you're not getting the one that everybody else, who's in the in-crowd should get. Okay? That's really true. Inhaled corticosteroids, that's a component of the treatment, particularly if symptoms are not adequately controlled with bronchodilators alone, or if a person is having frequent exacerbations of COPD that are not something else, like heart failure or pneumonia or something else. We use inhaled corticosteroids. Supplemental oxygen with rest and or exertion and or sleep is important if your oxygen levels are going in an unsafe range, which is generally less than 90%, but the real steep cutoff, we get to 88% saturation of your blood oxygen. That's when we think about starting supplemental oxygen. Next. And non-invasive assisted ventilation, something called CPAP, or continuous positive airway pressure, especially if there is something called sleep apnea that's also present. And there's something called BiPAP, which is a cousin of that, where the breathing is assisted and you're actually getting air in and out of your lungs at different levels of pressure with breathing in and breathing out. Some people need that. Some people need that every night. Some people only need it during an exacerbation if they have a severe event. But sometimes things get bad enough that your own breathing muscles can't keep the air moving in and out effectively enough, and you need to have this BiPAP treatment. And to tell, we generally need to have a sleep study to assess. Wait, back one, please. One thing you'll notice is not on this list, stem cell therapy. Anybody ever read about the stem cell therapy online? Okay, so I encourage you to go to the American Thoracic Society website, thoracic.org, and there is a patient information page on that. Suffice it to say, there is no approved stem cell therapy for COPD at this time. The idea is great. You take cells that are undifferentiated and somehow convince them to develop into healthy restorative lung cells to restore the areas of emphysema. But there is no such therapy at this point in time. There's a lot of research about it, but there is no approved therapy, and a lot of people are getting hooked into paying a lot of money for something where they're literally often taking your blood out, spinning it down, and putting your own blood back into you to the tune of $5,000 or $12,000. So be very careful of that. All right? Keep a lookout, because in the future, it could happen that we might get it someday. But right now, it's not an available therapy. Okay, next. I want to mention physical activity, because physical activity levels are low amongst individuals with COPD. They're probably lower than they should be amongst everyone without COPD too, but we know that they're low with COPD, and lower than other people of the same age without COPD. And it's important because if you look at this cartoon up here, or this graph up here, what you can see is this is the probability of survival. Low is down here, high is up here, and this is time over follow-up. So people who remain active with COPD have a much greater chance of survival over time than people who are sedentary, and people who are very inactive have a greater risk of dying than people who remain active. This is very important, and it again factors into the issue of pulmonary rehab, which I'll touch on in just a second. But high physical activity levels are also associated with a slower loss of lung function. That is, you keep your lungs itself stable over time. There's less inflammation in the body, and there's decreased risk of ending up in the hospital as well if you remain physically active. So that's really important. Next. So that leads me just to mention, and I know there was extensive discussion already today of pulmonary rehab, so we'll go through this quickly. Did you see this official definition yet of pulmonary rehab?
No.
Okay, so let's just go through a couple of things, and we'll do it quickly. This is a healthcare professional's take on pulmonary rehabilitation, and I'm pretty sure, seeing some of the faces in this room and knowing who the other presenters were today, that we're all on the same page about this, but I might just say it in a slightly different way. So this is the official published definition from our international document on what is pulmonary rehabilitation. This is from 2013. It's a comprehensive intervention based on a thorough patient assessment, followed by patient-tailored therapies, which include but are not limited to exercise training, education, and behavior change, designed to improve the physical and psychological condition of people with chronic respiratory disease and promote the long-term adherence to health-enhancing behaviors. Next. That's a bit of a mouthful. Again, it encompasses many things. But let's boil it down to what are the goals. We're trying to reduce symptoms. We're trying to improve exercise performance and promote autonomy. And again, by exercise, I mean not just going out and doing heavy-duty exercise, because you might all say, well, I gave that up a long time ago, but I'm talking about daily activities for exercise, just as much as other forms of sort of conventional, training types of exercise. We want to encourage people to increase their participation in daily activities, enhance their health-related quality of life, and promote long-term health-enhancing behavior. And by that, this is not meant to be some punitive effort, pulmonary rehabilitation. It's meant to be something that promotes wellness. So health-enhancing behaviors would be things like getting your immunizations, smoking cessation, keeping physically active or getting physically more active if you haven't been physically active, and recognizing exacerbations and partnering with your healthcare providers so you can interrupt that before it hits you really hard. Okay, that's what we mean by health-enhancing behaviors. Next. So what is pulmonary rehabilitation really? Well, it's a structured and supervised exercise reconditioning program, usually the upper and lower extremities, usually a combination of endurance-type aerobic activities, such as walking or cycling, combined with strengthening exercises. Because we could do strength exercises, but it won't improve your endurance, and we could do endurance exercises, and it won't improve your strength. And you need both to get through your day feeling well. As part of it, there's also educational sessions that foster those health-enhancing behaviors. Put another way, help you know as much about your condition as you possibly can so that you can take control of it, rather it taking control of you. And as part of pulmonary rehab, we do a broad-ranging patient assessment. We measure people's exercise capacity, their shortness of breath, their health status, the impact of their condition on their well-being in terms of things like anxiety, depression, and fear, and there are some other outcomes we can measure as well. The proven benefits. This is worldwide proven benefits. There's so much literature on this that it's not a question. These are not theoretical. This is demonstrated benefits across multiple populations throughout the world, that pulmonary rehab improves exercise tolerance, reduces dyspnea and leg fatigue, improves ability to perform activities of daily living, improves emotional function, reduces anxiety and depression, for example, enhances people's what we call self-efficacy, that is, their ability to cope with and manage their condition. It improves their knowledge and collaborative self-management, meaning working with your healthcare provider to be able to take control of your condition. It improves quality of life, and it reduces hospitalizations and unscheduled healthcare visits like the emergency room visits, and has potential, if one follows through with the activities that are promoted or started within the program, to increase your physical activity level. There are lots of reasons why people either don't access or don't take up pulmonary rehabilitation. So one of the striking things about this is that fewer than 50% of people who are offered pulmonary rehabilitation actually choose to go. There's a lot of people who are recommended to have it who don't have a program in their area. That's a little bit of a different problem. We have that problem too. We also have the problem that healthcare providers don't recommend it enough. They don't even know about it enough on a broad level. But if we just look at factors that have been studied as to things that people with chronic respiratory disease have said as to what barriers were for them, transportation is a big one. Lack of support. They don't feel that their caregiver or family member supports them doing it. They may have other priorities. They may be worried that it'll make them worse, or they may not feel that they're ill enough to do it. And it feels like it disrupts people's daily routine. But one thing I want to call your attention to is a survey that we did. It was a worldwide questionnaire a couple of years back to nearly 1,700 people who responded to this across multiple countries. We had a substantial percentage of people, 20 to 25%, who said they never heard of it. In this day and age, that's really horrible, because it's such a well-established, proven, beneficial, cost-effective therapy for COPD and other forms of chronic respiratory disease. So many people have never heard of it, and others feel like they aren't sure it'll help, or they don't get enough information, and there's a host of other problems. So what I would encourage you to do, if you have never heard of it, is to ask your healthcare professionals about it. If you have heard of it and had the chance to participate, that you encourage at least 10 other people that you've come across in your travels to ask about it. We need the general public and people who have chronic respiratory disease to speak up knowledgeably to demand access to services. And this, together with other efforts, will help more people get it. And I'm very involved with the American Thoracic Society and European Respiratory Society. We're hoping to gear up and launch a big public awareness campaign about this in the near future. Next. So just to finish up then, you've probably all seen and heard, we have our team here from the Winchester Chest Clinic. We have in the Winchester Chest Clinic over at Yale our Yale COPD program. I and my colleagues, Jill Stewart, Dr. Tacular, Marjorie Cullinan, Sue Ayetzi, and Deborah Delamonica. Sue is over here with me, and colleagues from the Yale Center for Asthma and Airways Disease, Terry Levish and Emma Stewart. Jill Stewart, our APRN, is actually down in Temple University attending a fabulous program on COPD today, so she couldn't be with us. But we work very closely with the Yale Center for Asthma and Airways Disease, and I'll come back to that in just a second. But our mission at the Yale COPD program is to provide comprehensive diagnosis, patient assessment, and patient-centered disease management across the spectrum of disease subtypes and severity, and to provide collaborative care across healthcare venues, meaning as people transition from outpatient to inpatient if they end up hospitalized and back home. Okay, next. So we focus on wellness and well-being. I think my take on that I emphasized earlier. We do at times really have to focus on interrupting a cycle of recurrent hospitalizations or exacerbations. And just very, very quickly, we focus on making sure we have the right diagnosis and making sure that we have a diagnosis in the first place and that it's the correct one. Next. We also look for what are the triggers of someone's exacerbations and try to really figure out, okay, well, if we can identify what are the triggers, then we have a much better chance of interrupting that cycle than if we don't look at the sub-things that might be causing it. Next. Smoking cessation, and to emphasize again, vaccinations again. Optimizing the medical treatment, the pharmacotherapy. Next. Identifying and treating anxiety and depression. Now, we don't ourselves in the Yale COPD program, we're not health psychologists, and we're not experts on mental health, but one of our focuses is to try to identify when that issue is affecting people and to make sure that we get help for it as needed. Identifying social and logistic factors associated with hospitalizations and readmissions is also very important, and referrals to pulmonary rehab. As some of you who are in this room who know me, I'm probably the biggest nag for pulmonary rehab ever walked this earth, but it's with good reason. Early post-discharge medical follow-up, and overall integrated care, in other words, optimizing transitions of care. And we work very closely with a group within the hospital system as a whole at Yale New Haven Health to try to fine-tune these transitions to make it easier for people. Next. So again, our clinic is located in the Winchester Chest Clinic at Yale New Haven Hospital on York Street. This is an email and a phone number if anybody wants to make referrals. Our referral specialist is Louisa Sastre. And I want to again highlight the fact that we work very closely with our Yale Center for Asthma and Airways Disease, and we have opportunities to participate in clinical research. And those opportunities vary over time, and different clinical trials come along and some novel therapies that we have to offer. And so the contact information, not only is our team here at this table right up here, but we have this website here, the Yale Center for Asthma and Airways Disease is listed here. In case anybody's interested, feel free to contact us in that. Next. And just lastly, I've got on here some resources that would potentially be very helpful to you. Obviously, the COPD Foundation does an absolutely heroic amount of work on behalf of raising public awareness, helping people with COPD get connected, working together partnering between people with COPD and healthcare professionals in multiple disciplines to tackle this disease. And I might mention there is also, as a result of efforts of the COPD Foundation and multiple people at the National Institute of Health and multiple healthcare providers throughout the country, there now recently, just this last year, was published a national action plan for COPD. So this disease is getting its just due attention in a way that it wasn't in a few years back. This Gold COPD website is a very useful resource for knowledge. Also, this wonderful one called Living Well with COPD. I really recommend that. It's terrific information both for healthcare professionals and for people with COPD and their families. And I will finish there, and I'd like to thank you for attention and can open for discussion.